I want you to take a moment and just conceptualize the human face as a really hyperactive public theatrical stage.
Oh, that's a brilliant way to picture it.
Right, you got the constant movement of the mimetic musculature,
Correct.
the dynamic expressions, and just this overwhelming influx of sensory data.
Pouring in from everywhere.
Exactly. Pouring in through the orbits, the nasal cavity, the oral cavity. It is entirely exposed to the world.
It's completely chaotic.
It is chaotic by design. But if the face is the stage, then the cranial fossa is the secure, heavily fortified vault buried deep beneath it.
I love that analogy.
Thanks. It's this pitch black, immaculately protected chamber where the brain actually rests. And it's suspended within these layers of defense, physically isolated from all the chaos of the external environment.
Right, but still connected.
Exactly. Threaded with these highly specific pathways that represent, well, extraordinary vulnerability.
And that spatial dichotomy is really the perfect foundation for our deep dive today. We are looking at the internal environment of the skull,
which is so much more complex than people realize.
Oh, absolutely. And our goal here isn't to simply rattle off a catalog of anatomical landmarks. I mean, you can read a textbook for that.
Right. Exactly.
We're trying to construct a functional three-dimensional mental model of the cranial fossa. Because when you look at the calvaria, it's really tempting to view it as just a passive, empty container.
Like a bowl.
Like a bowl, yeah. But the cranial fossa is an actively tensioned, highly structured environment, and it's built entirely around three physiological imperatives.
Containment, support, and flow.
Spot on. Containment, support, and flow.
I think it's vital to anchor our discussion in that framework.
Yeah.
Because a really common trap in early anatomical study is treating these structures as, static.
Oh, totally. Just memorizing names.
Right. But every ridge, every foramen, every fibrous reflection, they all exist to solve a dynamic physical problem.
Absolutely.
So the guiding principle we really need to keep at the forefront of our minds is this. We are studying structure in service of function.
And how that precise structure shapes disease, intervention, and ultimately clinical outcome.
Exactly. Which brings us to the first line of defense.
Right, because the cerebrum itself is, well, it's incredibly fragile.
Oh, it's basically jelly, right?
Pretty much. In its fresh state, it is almost gelatinous. It's completely incapable of supporting its own weight outside of a fluid medium.
Let alone withstanding, friction against raw, ossified bone.
Exactly. That would be disastrous. So it requires an interface. And that interface is the meninges, the three distinct layers enveloping the central nervous system.
You've got the pia mater, the arachnoid mater, and the dura mater.
Right. The pia mater investing the gyri and sulci, the arachnoid mater forming the subarachnoid space, and then the outermost layer, the dura mater.
And our focus really rests heavily on the dura today, doesn't it?
It does, because it dictates the structural integrity of the entire cranial vault.
The tough mother, literally translated.
And it is entirely unyielding. If you've ever handled it in a dissection, you know the dura is this thick, dense, inelastic, fibrous membrane.
Yeah, it's like a heavy canvas.
It really is. It absolutely refuses to conform to the delicate folding contours of the cortex inside it.
It just bridges right over them.
Exactly. It essentially creates a secondary, rigid, internal wall. But the real structural secret of the dura mater is that it's a composite material.
Oh, right.
Yeah, it appears macroscopic as a single sheet, but functionally and embryologically, it actually consists of two distinct layers.
Let's break down that composite architecture.
Sure. So you have the outer periosteal layer and the inner meningeal layer.
And they do very different things.
They do. The outer periosteal layer functions precisely as its name suggests. It is the internal periosteum or endocranium of the calvarial bones.
Meaning it's stuck right to the skull.
Right to it. It's highly vascularized and remains in direct, intimate contact with the inner table of the skull.
And it's physically anchored there.
Yes, by Sharpie fibers. These are microscopic, penetrating bundles of collagen that act as biological spot welds.
Biological spot welds. I love that. And those Sharpie fibers are heavily concentrated at the cranial sutures, aren't they?
They are. The adhesion at the sagittal, coronal, and lambdoid sutures is exceptionally strong.
Which becomes super important later.
Oh, absolutely. It's a crucial limiting factor in how extradural pathologies spread, as we'll discuss when we get to hematomas.
Right. So that's the outer layer.
Yes. And sitting immediately deep to that is the meningeal layer. For the vast majority of the cranial vault's surface area, this inner meningeal layer is seamlessly fused to the outer periosteal layer.
So they act as a single impenetrable shield.
Precisely.
But, a shield that needs to be maintained. Which brings us to the vascular supply.
Always a vital topic.
Because if the periosteal layer is welded so tightly to the inner table of the skull, and it's made of this dense fibrotic tissue, how does it actually receive its arterial supply? It's a demanding tissue.
It is, and the vascular solution is elegant, though it's fraught with risk. The meningeal arteries do not run within the subarachnoid space with the cerebral vessels.
Okay, so where are they?
They travel entirely external to the dura. They occupy the precise potential space between the outer periosteal layer and the inner table of the skull.
Wow, so they're sandwiched in there.
Exactly. And to accommodate this, the arteries carve deep, arborizing grooves directly into the compact bone of the calvaria.
Like a river cutting a channel into bedrock over time.
That is exactly what it looks like on the bone. The bone just remodels around the arterial pulsation.
And while there is an anterior, an accessory, and a posterior meningeal artery, the dominant vessel, the one that really dominates the clinical landscape, is the middle meningeal artery.
Oh, without question, it is the defining vessel of the lateral calvaria.
Let's trace its origin for a second.
Right. So the middle meningeal artery arises extracranially. It comes from the maxillary artery within the infratemporal fossa.
So it's outside the skull.
Yes. So it requires a gateway to enter the vault. And it finds it at the cranial base, ascending vertically through the foramen spinosum in the greater wing of the sphenoid bone.
So it shoots up through that tiny hole.
It does. And once it clears the foramen spinosum, it enters the middle cranial fossa and immediately begins its arboreal distribution.
Spreading out like a tree.
Exactly, branching out to supply the vast majority of the supratentorial dura.
But the anterior branch is particularly notorious, isn't it? Because of its trajectory.
It's arguably one of the most dangerous anatomical relationships in the head. It courses anteriorly and superiorly, running directly deep to the pterion.
The pterion being that H-shaped sutural junction on the side of the head.
Right, where the frontal, parietal, squamous temporal, and the greater wing of the sphenoid bones all meet.
Which is notoriously thin.
It is the thinnest, structurally weakest point of the lateral skull. So you have the most significant arterial supply to the dura running beneath the most fragile section of the calvaria.
That just seems like a massive design flaw.
It really does. And we will return to the clinical fallout of that specific anatomical relationship shortly.
I can't wait. But before we move off the supply to the dura, what about the accessory, anterior, and posterior meningeal arteries? They handle the periphery, right?
They do. The accessory meningeal artery, which also arises from the maxillary artery, enters through the foramen ovale.
Correct.
Its primary role is supplying the extracranial structures nearby, but a branch ascends to supply the trigeminal ganglion and the surrounding dura.
What about the anterior ones?
The anterior meningeal branches are sourced from the ethmoidal arteries, which themselves are branches of the ophthalmic artery.
So coming back from the eye area.
Exactly. And then the posterior cranial fossa, that deep protected well housing the cerebellum and brainstem, is supplied by the posterior meningeal branches.
Source from where?
They originate from the ascending pharyngeal, occipital, and vertebral arteries, and they enter through the jugular foramen and the foramen magnum.
So the vault is heavily armored, tightly anchored, and richly vascularized.
It is.
But it's also highly monitored. I mean, the brain parenchyma itself is insensate.
Right. Right. You can cut cerebral tissue without inducing pain.
Which is always wild to think about.
Yeah.
But the dura mater is exquisitely sensitive to stretch and tension.
Oh, incredibly sensitive.
So how is that sensory input routed back to the central nervous system?
Well, the primary sensory innervation of the supratentorial durso, everything above the tentorium cerebelli, is provided by the trigeminal nerve, cranial nerve V.
Makes sense. The great sensory nerve of the head.
Exactly. The ophthalmic division, or V1, supplies the anterior cranial fossa and the falx cerebri. The maxillary V2 and mandibular V3 divisions supply the middle cranial fossa.
But that changes further back, right?
It does. Once you drop below the tentorium into the posterior cranial fossa, the sensory innervation shifts away from the trigeminal system entirely.
It shifts to the vagus nerve, cranial nerve X.
Yes, and the upper cervical nerves, specifically C1, C2, and C3.
Which often travel transiently with the hypoglossal nerve, CN12.
Spot on. And this actually explains referred pain patterns perfectly, doesn't it?
Oh, absolutely.
Yeah.
Because the supratentorial dura is supplied by the trigeminal, if you have irritation there, like a subarachnoid hemorrhage or severe meningitis, it often refers pain to the face and forehead.
Right, following the trigeminal pathways.
But irritation of the posterior fossa dura refers pain to the back of the neck, causing that classic neutral rigidity.
That is the precise physiological mechanism. But there is a developmental quirk regarding the innervation of the middle cranial fossa that I just find fascinating.
Oh, I know what you're going to talk about. It highlights how anatomy is shaped over embryological time.
It really does. You have nerve fibers that originate inside the cranial vault, but instead of remaining intracranial to supply the local meninges, they actually exit the skull through a foramen.
They leave the building.
They leave. They travel extracranially for a short distance and then execute a complete U-turn.
Just to come right back in.
Exactly, re-entering the cranial fossa through an adjacent foramen just to innervate the dura.
It's the nervous system's equivalent of taking the scenic route.
Truly. The nervus spinosus is the classic example of this.
Right, it's a meningeal branch of the mandibular nerve, V3.
Yes. So the mandibular nerve exits the vault down through the foramen ovale.
Okay, so it's out.
It's out. Then the nervus spinosus branches off, turns around, and climbs back up into the skull through the foramen spinosum.
Traveling right alongside the middle meningeal artery.
Exactly.
But why? I mean, why would evolution select for such an inefficient pathway?
Well, it comes down to embryonic folding and the independent development of the chondrocranium versus the peripheral nervous system.
The timing is out of sync.
Right. The neural pathways are laid down remarkably early in development. As the cartilaginous precursors of the skull base grow, expand, and eventually ossify around these established nerves, structures get displaced.
So the bone forms around the nerves.
Yes. The foramen ovale and foramen spinosum form in the sphenoid bone, literally around the nerves and vessels.
So the nerves aren't actively seeking a U-turn.
Not at all. They are just maintaining their original target connections, while the bony architecture essentially erupts and solidifies around them.
Dragging the pathways into these convoluted roads.
Precisely.
Structure in service of function, heavily modified by the constraints of embryology.
A great way to summarize it.
All right, so we've established the dual-layer shield. We have the periosteal layer anchored to the bone.
Right.
But earlier, we established that containment isn't enough. The vault must provide internal support.
Absolutely vital.
Because the brain is subject to immense physical forces during normal human movement. I mean, rotational acceleration, sudden deceleration.
Just turning your head quickly.
Exactly. Without internal scaffolding, the cerebral hemispheres would simply crush each other. Or they'd shear against the rough cranial base.
Which would be catastrophic. And this brings us to the dural reflections. We noted that the periosteal and meningeal layers of the dura are generally fused.
Right, like one single sheet.
However, at highly specific, structurally critical junctions, the inner meningeal layer abruptly detaches from the periosteal layer.
It just peels away.
It dives deeply into the cranial cavity, folding back on itself to create these thick, taut, bilaminar partitions.
2 layers thick.
Exactly. These reflections act as internal bulkheads. They subdivide the cavity and severely restrict the displacement of the brain.
Let's visualize the major load-bearing walls then. The most prominent is obviously the falx cerebri.
Yes, falx being the Latin for sickle.
Right. It's a massive, vertically oriented, crescent-shaped sheet of dura that descends strictly down the longitudinal fissure.
It physically separates the left and right cerebral hemispheres.
But to really understand its mechanical role, we have to look at its attachments.
We do. Anteriorly, it is sharply papered and anchors securely to the crista galli of the ethmoid bone.
Which is a literal bony crest projecting superiorly into the anterior cranial fossa.
Yes, like a rooster's comb. And from that anterior anchor, it sweeps posteriorly, broadening out considerably as it attaches along the entire midline of the cranial vault.
All the way back to the internal occipital protuberance.
Exactly.
So it's under constant anterior-posterior tension.
Like a drawn bowstring.
Right. It prevents the massive cerebral hemispheres from sloshing laterally. I mean, if you suffer a lateral impact to the head, the falx cerebri prevents the contralateral hemisphere from compounding the injury by crashing into the ipsilateral hemisphere.
It acts as a massive shock absorber and baffle, but vertical support is equally crucial.
Why is that?
Because the cerebral hemispheres are vastly heavier than the cerebellum beneath them.
Oh, right, which necessitates the tentorium cerebelli.
Yes. This is a horizontal counterpart to the falx cerebri. It functions as a rigid hyprotic shelf.
Literally forming a roof over the posterior cranial fossa.
Exactly. The heavy occipital lobes of the cerebrum rest securely on the superior surface of this tent,
completely isolating and protecting the delicate cerebellar hemispheres located within the compartment below.
And the structural relationships here are just fascinating. The posterior falx cerebri actually merges directly into the superior surface of the tentorium cerebelli.
Oh, like the main mast of a ship attaching to the deck.
That is a perfect structural analogy.
But, a horizontal partition presents a massive anatomical problem.
Because the central nervous system must remain continuous.
Right. The brainstem has to descend from the cerebrum to connect with the spinal cord. How do you pass a vital, highly sensitive structure through a rigid, taut membrane?
You build a doorway.
Naturally.
The peripheral margins of the tentorium cerebelli are firmly attached to the bony ridges of the skull, the clinoid processes, the petrous part of the temporal bone, and the transverse ridges of the occipital bone.
But the anterior medial margin is completely free.
Yes, it forms a deep U-shaped concavity known as the tentorial incisure, or the tentorial notch.
And the midbrain passes directly through this incisure.
It does.
Now, this tentorial incisure is a structural marvel, but it is also one of the most clinically dangerous pieces of real estate in the human body.
Unquestionably.
Because the edge of that tentorium is completely unyielding.
Yeah.
I mean, if there is a mass occupying space in the supratentorial compartment like a tumor or a severe hemorrhage, the pressure forces the brain tissue downwards.
Because it's the only way out.
Right. And the medial aspect of the temporal lobe, a structure called the umpuscus, gets pushed over the edge of the tentorium.
And physically crushed against that rigid dural margin.
Which is called uncal herniation.
Yes, and the immediate consequence is compression of the adjacent structures passing through that very narrow space.
Most notably, the oculomotor nerve, cranial nerve third.
Exactly. The parasympathetic fibers controlling pupillary constriction run on the very superficial aspect of the oculomotor nerve,
making them exquisitely vulnerable to this mechanical compression.
They get knocked out almost immediately. And this is the anatomical genesis of the blown pupil.
A fixed, dilated pupil.
Yes, indicating catastrophic, rapidly rising intracranial pressure.
So we see that direct line from structural support to pathological vulnerability.
It's all connected.
Beyond the falx cerebri and the tentorium cerebelli, there are smaller, highly specialized reflections too.
Yes, there's the falx cerebelli, which is a minor vertical partition.
Essentially a smaller version of the falx cerebri.
Exactly, separating the two cerebellar hemispheres inferior to the tentorium. But the diaphragma sella, now that deserves deep consideration.
The diaphragma sella, it's tiny, isn't it?
It is diminutive. It's a circular horizontal fold of dura, and it spans the sella turcica of the sphenoid bone.
Sella turcica translates to Turkish saddle, right?
It does, and it's the bony depression that houses the pituitary gland. The diaphragma sella forms a secure, taut roof over the hypophyseal fossa, essentially enclosing the gland.
But the pituitary gland is the master endocrine regulator. It relies on constant neurochemical communication with the hypothalamus sitting directly above it. If you seal the pituitary in a dural vault, you sever the communication.
Which is why the diaphragma sella features a precise, centrally located aperture.
A tiny perforation.
Yes. This perforation accommodates the infundibulum, the pituitary stalk, allowing the neural and vascular connections from the hypothalamus to reach the pituitary gland uninterrupted.
It is a phenomenal example of anatomical tolerance. I mean, the aperture must be large enough to allow the passage of the highly vascularized infundibulum.
But small enough to prevent the overlaying optic chiasm or arachnoid mater from herniating down into the sella turcica.
Which is exactly what happens when that aperture is congenitally too large. You can get empty sella syndrome.
Right, where cerebrospinal fluid presses down, basically flattening the pituitary gland against the floor of the fossa.
Again, minor structural deviations yielding significant clinical phenomena.
It's a recurring theme. Finally, we have the dural reflection over the trigeminal cave, or Meckel's cave.
Right, for trigeminal nerve.
Yes, the trigeminal nerve possesses a massive sensory ganglion, housing the cell bodies for the sensory innervation of the entire face.
And this trigeminal ganglion rests in a shallow depression on the anterior surface of the petrous temporal bone.
Correct. The intermeningeal layer of the dura sweeps over this depression, creating an invaginated pouch cave, essentially.
That blankets and protects the ganglion.
While also bathing it in cerebrospinal fluid.
Okay, so synthesizing this internal architecture, the falxes provide vertical restriction against lateral shear.
Right.
The tentorium provides horizontal load-bearing support.
Exactly.
And the diaphragma sella and the trigeminal cave provide highly localized, specialized protection for critical neural hubs.
These are the internal load-bearing walls of the skull.
But as we pivot to the concept of flow, we uncover the secondary and perhaps most ingenious function of these load-bearing walls.
Yes, the plumbing.
Because when that intermeningeal layer abruptly detaches from the outer periosteel layer to form a reflection, say diving inward to form the falx cerebri, it doesn't fold cleanly at a right angle.
No, it leaves a geometric void at the hinge.
Right. If you take a piece of thick, rigid leather and fold it sharply in half, the crease doesn't sit perfectly flush.
You are left with a triangular gap running along the length of the fold.
And in the cranial vault, those geometric voids are not wasted space.
Not at all. They form the dural venous sinuses.
And this is where the cardiovascular physiology of the brain fundamentally diverges from the rest of the human body.
It completely throws out the rulebook. The dural venous sinuses are the primary drainage system for the brain. But calling them veins is, frankly, a gross anatomical misnomer.
Because they're nothing like systemic veins.
Nothing alike. A systemic vein in the appendicular skeleton, like the femoral or saphenous vein, is a flexible, muscular, collapsible tube.
It contains a tunica media capable of venoconstriction.
Exactly. And critically, it features one-way intimal valves to ensure unidirectional flow against gravity.
But the dural venous sinuses possess absolutely none of these histological features.
Zero. They are simply endothelial-lined corridors enclosed by the taut, unyielding fibrous layers of the dura mater.
They are entirely rigid.
Yes, they cannot undergo vasospasm, they cannot dynamically expand to accommodate volume surges, and they contain absolutely no valves.
But this rigidity is an evolutionary necessity, not a flaw.
Oh, it's brilliant design. Consider the physics of the upright human posture. The brain is situated significantly higher than the right atrium of the heart.
Right.
If the cerebral venous drainage system were composed of thin-walled, collapsible veins, the negative hydrostatic pressure generated when we stand upright would instantly cause the veins to collapse shut.
Like sucking a straw flat.
Exactly. Venous return from the brain would cease, and cerebral perfusion would instantly fail. You'd pass out every time you stood up.
So the rigid fibrotic walls of the dural sinuses keep the channels permanently stented open.
They are utterly impervious to negative pressure collapse.
That answers the question of why they are rigid. But it raises a really profound physiological question.
How does the blood move?
Yeah. If I have a complex network of fluid channels and they lack valves to prevent retrograde flow, how is the directional flow of blood maintained? I mean, how does it avoid simply pooling or flowing backward during fluctuations in intrathoracic pressure, like when we cough or strain?
It's a great question. Directional flow within the dural venous sinuses is dictated entirely by unrelenting pressure gradients.
Just pure fluid dynamics.
Pure physics. The continuous arterial inflow into the rigid cranial vault creates a steady state of intracranial pressure.
So blood from the cerebral veins, from the diploic veins within the skull marrow, and from the meninges itself constantly feeds into these sinus channels.
Right. This continuous high-pressure input at the headwaters basically forces the venous blood forward along the rigid corridors,
moving from areas of high relative pressure toward the ultimate low-pressure sink,
which is the internal jugular vein as it exits the skull base.
So it is essentially a gravity-assisted pressure-fed storm drain system built directly into the foundational walls of the neurocranium.
That's exactly what it is.
Let's trace that fluid journey, mapping the spatial relationships of these sinuses. It provides a phenomenal way to visualize the internal topography of the vault.
Let's do it. We begin superiorly, right at the apex of the vault. Running within the attached superior border of the falx cerebri is the superior sagittal sinus.
Okay, right at the top.
It originates anteriorly, near the crista galli we mentioned, and courses posteriorly along the midline, tracing the undersurface of the sagittal suture.
And it gradually widens as it progresses backward.
Yes, because it's constantly receiving venous blood from the superior cerebral veins along the way.
But the superior sagittal sinus manages more than just venous blood, doesn't it?
It does. It is the primary site of cerebrospinal fluid reclamation.
Right, because the brain floats in CSF, which is continuously produced by the choroid plexus within the ventricles.
And that fluid must be reabsorbed into the venous system to prevent hydrocephalus.
So how does it get into the sinus?
Protruding into the lateral extensions of the superior sagittal sinus, these spaces called the lateral lacunae, are arachnoid granulations.
Little tufts.
Yes, tufted, macroscopic projections of the arachnoid mater. They act as one-way pressure valves,
filtering CSF directly out of the subarachnoid space and dumping it into the venous blood of the sinus to be recycled.
Precisely.
So that handles the superior margin of the falx cerebri. Moving down to the inferior, free margin of that sickle-shaped partition, we find the inferior sagittal sinus.
It is significantly smaller, and it runs posteriorly along the free edge of the falx.
And where does that one go?
As the inferior sagittal sinus reaches the posterior aspect of the falx cerebri, it unites with a major deep vein draining the internal core of the brain, the great cerebral vein, or the vein of Galen.
Oh, right. And the convergence of these two vessels creates the straight sinus.
Exactly. The straight sinus runs directly along the geometric intersection where the vertical falx cerebri fuses with the horizontal tentorium cerebelli.
That intersection we talked about earlier.
Yes. It acts as the central drainage conduit for the deep cerebral structures. Both the superior sagittal sinus and the straight sinus are converging on the exact same anatomical landmark at the posterior pole of the skull.
They converge at the internal occipital protuberance.
Yes, this junction is the confluence of sinuses, or the torcular hierophile.
It's a massive dilated intersection, isn't it?
Huge. The superior sagittal sinus, the straight sinus, and the smaller occipital sinus, which drains upward from the foramen magnum, they all pool their venous return right there.
From the confluence, the blood must diverge to reach the lateral exits.
Yes, it flows laterally into the paired transverse sinuses.
And these run horizontally, encased within the attached posterior margins of the tentorium cerebelli, basically grooving the occipital bone.
Exactly. And as they reach the lateral extremes of the posterior cranial fossa, encountering the petrous portion of the temporal bone, they execute a sharp inferior turn.
Carving a deep S-shaped trajectory.
They do.
And maintaining the grand anatomical tradition of naming structures after shapes, this S-shaped descent becomes the sigmoid sinus.
The sigmoid sinuses plunge inferiorly and medially, grooving the mastoid part of the temporal bone.
And this proximity is super clinically relevant, right?
Very. Middle ear infections, otitis media, can erode through the thin bone here, leading to a catastrophic sigmoid sinus thrombosis.
Wow. And then where does the sigmoid sinus terminate?
It finally terminates as it reaches the jugular foramen at the cranial base.
And this is where the magic happens.
Yeah.
The moment the venous blood passes through the jugular foramen and exits the neurocranium, the rigid dural walls just vanish.
They do. The vessel immediately regains a tunica media, it develops valves, and it becomes a flexible, true vein, the internal jugular vein.
The pressure-dependent, rigid plumbing system gives way to the standard systemic venous architecture.
Seamlessly.
That covers the primary posterior drainage pathway. But we really must address the most intricate, clinically hazardous venous structure in the anterior region.
The cavernous sinus.
Right. You mentioned earlier it sits flanking the sella turcica.
The cavernous sinus is just unparalleled in its anatomical complexity. It is located in the middle cranial fossa, sitting on either side of the body of the sphenoid bone.
But it's not like the others.
No, unlike the superior sagittal or transverse sinuses, which are essentially open triangular tubes, the cavernous sinus is a labyrinth.
It's highly trabeculated.
Exactly, resembling a porous sponge filled with venous blood. It receives flow from the superior and inferior ophthalmic veins of the orbit, the superficial middle cerebral vein, and the sphenoparietal sinus.
But the cavernous sinus doesn't just collect blood. It acts as a critical transit hub.
Because of its location, major neurovascular structures must traverse it to reach the face and the orbits.
And this creates a high-stakes, incredibly congested anatomical environment.
We will break down exactly what passes through the cavernous sinus when we explore its clinical pathologies, which I think we should probably do now.
Yeah, let's pivot to that. We have established this phenomenal framework of unyielding support and pressure-dependent flow.
Right.
But the great paradox of the cranial vault is that its greatest strength, its rigidity, is also its fatal flaw.
The rigid vault is entirely intolerant of added volume.
Which brings us directly to the Monroe-Kelly doctrine.
A fundamental principle of neurophysiology. The cranial cavity is a closed, incompressible box containing three elements.
Brain tissue, which is roughly 80%.
Cerebrospinal fluid, about 10%.
And blood, the final 10%.
Right, because the overall volume of the vault is absolutely fixed by the calvaria. An increase in the volume of any one of those components, or the introduction of a new mass, like a hematoma, must be accompanied by an equal and opposite decrease in the volume of the others.
Initially, the system compensates, right?
Yeah.
It displaces CSF into the spinal canal and squeezes venous blood out of the sinuses.
It tries its best. But once those compensatory mechanisms are exhausted, the pressure inside the vault spikes exponentially.
This sets the stage for our first major clinical correlation, the extradural or epidural hematoma.
Let us trace the pathology from the initial trauma. We must return to the middle meningeal artery.
Ascending through the foramen spinosum and branching extensively between the outer periosteal layer of the dura and the inner table of the skull.
And specifically, the anterior branch running deep to the pterion.
The pterion is terrifyingly fragile. It is the junction of four bones, and the skull is remarkably thin there.
So consider a patient presenting to the emergency department. They were struck in the lateral aspect of the head, a baseball, a lateral impact in a motor vehicle collision, or perhaps a severe fall.
The force of the impact bends the calvaria inward.
The bone may snap back without fracturing, or it may sustain a linear fracture across the pterion. In either scenario, the shearing force tears the middle meningeal artery coursing tightly against the bone.
The crucial variable here is that this is an arterial bleed.
Exactly. The middle meningeal artery is pumping systemic high-pressure arterial blood.
And the bleeding occurs into a potential space.
Right, because the periosteal dura is firmly anchored to the bone by Sharpie fibers.
But the hydraulic pressure of the arterial blood is immense.
It overcomes the biological spot welds, forcefully peeling the dura mater away from the inner table of the calvaria.
It is actively dissecting the tough mother off the bone.
As it peels, the blood pools, creating a rapidly expanding lens-shaped or biconvex hematoma.
And the clinical presentation of this specific biomechanical process is legendary. The lucid interval.
Yes. The classical presentation often begins with a brief loss of consciousness at the moment of impact,
due to the concussive force applied to the reticular activating system in the brainstem.
But then the patient awakens. They may seem slightly concussed, complaining of a headache, but their Glasgow Coma Scale score is remarkably normal.
They're talking, ambulating, demonstrating no gross neurological deficits.
But beneath the calvaria, the torn artery is still pumping. The hematoma is enlarging.
So why don't they exhibit immediate symptoms?
Because the initial volume of the arterial blood is being accommodated by the Monro-Kelly compensatory mechanisms. CSF and venous blood are being shunted out of the vault to make room.
The patient appears lucid because the cerebral parenchyma hasn't yet sustained critical compression.
However, the capacity to compensate is finite.
Once that threshold is crossed, the intracranial pressure decompensates.
Rapidly. The expanding hematoma, contained laterally by the unyielding skull and constrained at the edges by the tight sutural attachments of the dura, bulges medially,
directly compressing the cerebral hemisphere.
The clinical deterioration is precipitous and devastating. The patient develops an excruciating, escalating headache.
The rising pressure compresses the cortex, leading to severe drowsiness, confusion, and contralateral hemiparesis.
Weakness on the opposite side of the body due to compression of the motor cortex.
And as the entire hemisphere is pushed downwards, we return to the structural danger of the dural reflections we discussed.
The brain is forced toward the only available exit.
The tentorial incisure.
Exactly. The imptuncus of the temporal lobe herniates over the edge of the tentorium.
And that uncal herniation compresses the ipsilateral oculomotor nerve, CN3, against the rigid dural margin.
The parasympathetic fibers are knocked out first, resulting in a fixed, dilated pupil, the classic blown pupil that signals impending brainstem compression.
Without immediate neurosurgical intervention, specifically a craniotomy to evacuate the hematoma, relieve the intracranial pressure, and ligate the bleeding middle meningeal artery, the brainstem will be fatally crushed.
It is a phenomenal, terrifying demonstration of structure-shaping disease.
The tight adherence of the dura delays the onset, creating the deceptive lucid interval.
The high arterial pressure creates the mechanical peel.
And the rigid structures of the calvaria and tentorium guarantee the fatal compression.
It's all just physics and anatomy.
Let's shift our focus to pathology number 2, which requires us to dive back into the labyrinth of the cavernous sinus.
Ah, yes. The arteriovenous fistula.
To understand the genesis of an arteriovenous fistula in this location, we must examine the contents of the cavernous sinus.
Because it is not merely a pool of venous blood, it is heavily populated with vital structures.
Right. Running directly through the central venous blood pool, bathed entirely in low-pressure venous blood, is the internal carotid artery.
An artery traversing the interior of a vein.
I mean, that is a highly unusual anatomical arrangement, isn't it?
It is structurally unique. The internal carotid artery enters the cranial vault through the carotid canal, arches over the foramen lacerum, and then literally pierces the dura to run horizontally through the cavernous sinus.
It is shielded from the venous blood only by a thin layer of endothelium.
And traveling alongside the artery, also bathed in the central venous pool, is the abducent nerve, cranial nerve 6/6, which provides somatic motor innervation to the lateral rectus muscle of the eye.
And the crowding doesn't stop in the center. Embedded within the rigid lateral dural wall of the sinus itself is a vertical stack of critical nerves.
Superior to inferior, you have the oculomotor nerve, CN3, the trochlear nerve, CNIV, and the ophthalmic V1 and maxillary V2 divisions of the trigeminal nerve.
It is a massive neurovascular bundle packed into a tiny, rigid space.
The pathology begins with a severe fracture of the cranial base, often involving the sphenoid bone.
And the sheer force of the fracture can lacerate the internal carotid artery exactly at the point where it traverses the cavernous sinus.
Suddenly, you have a massive, high-pressure arterial blowout venting directly into a low-pressure, rigidly confined venous pool.
An arteriovenous fistula.
Yes, and because we established earlier that the dural venous sinuses are completely valveless, the massive influx of arterial pressure completely overwhelms the normal venous drainage pathway.
The blood does not simply flow forward into the petrosal sinuses.
The pressure gradient reverses violently. Arterial pressure blood is forced retrogradely backwards into all the tributary veins that normally drain into the cavernous sinus.
And the major tributaries are the superior and inferior ophthalmic veins draining the orbits.
You have systemic arterial pressure rocketing backwards into the delicate venous architecture of the eye sockets.
The resulting clinical presentation must be profound.
It is. The orbital veins become massively engorged, severely increasing intraorbital pressure. The patient develops pulsating exophthalmos.
The eyeballs are physically displaced, anteriorly protruding from the orbits.
And they visibly throb or pulsate in synchrony with the patient's radial pulse, driven directly by the arterial fistulous flow.
Wow. Furthermore, the conjunctiva becomes profoundly hyperemic and edemous, a condition known as chemosis.
But the mechanical pressure within the cavernous sinus itself is wreaking havoc on the embedded cranial nerves.
Which nerve typically succumbs to the pressure first?
Well, while the abducent nerve, CN-SAC, runs freely through the center of the sinus and is highly vulnerable, clinical observation frequently points to the oculomotor nerve, CN-THET.
What is that?
Because CN-THET is embedded in the superior aspect of the lateral dural wall. As the sinus becomes massively engorged and the rigid wall is forced outward, the oculomotor nerve sustains severe stretching and compression.
Which leads to a complex ophthalmoplegia paralysis of the extraocular muscles and a dilated, unreactive pupil.
Valveless veins, a highly confined space, an internal arterial rupture, and retrograde destruction. The anatomy perfectly explains the pathology.
Now, we have mapped the internal fortifications, the dural scaffolding, and the rigid fluid dynamics.
We have.
But the cranial fossa cannot exist in perfect isolation.
Yeah.
I mean, the brain must interface with the periphery. It requires specific, structurally sound gateways for transit.
How do things cross the boundary of the vault?
Right.
We can categorize these transit pathways into two functional groups: the venous bridges and the cranial nerve foramina.
Let us begin with the venous connections, specifically the emissary veins.
We noted earlier that the dural venous sinuses drain the brain and the meninges, but they also form crucial anastomoses with the extracranial venous system, the veins draining the scalp and the face.
These connections are achieved via emissary veins. They are small, valveless venous channels that physically pierce through the compact bone of the calvaria,
linking the external scalp veins directly to the deep intracranial dural sinuses.
Why build a porous roof, though?
The primary physiological rationale involves thermoregulation, specifically selective brain cooling.
Interesting.
During periods of intense physical exertion or hyperthermia, cooler venous blood from the expansive surface area of the scalp can flow inwardly through the emissary veins,
Entering the dural sinuses to help cool the underlying cerebral cortex.
Exactly. They also serve as critical pressure release valves. If intracranial venous pressure rises acutely, blood can shunt outward to the extracranial system.
But the defining characteristic of the emissary veins is their lack of valves. Flow direction is dictated entirely by pressure gradients.
Which means they are a two-way street.
And that bidirectional capability introduces a massive clinical vulnerability.
It does. The emissary veins represent a direct, unguarded conduit from the external environment into the sterile cranial vault.
Consider a patient with a severe bacterial infection on the scalp, or a deep pyogenic abscess on the face, particularly in the region around the nose and upper lip.
Ah, the classic danger triangle of the face.
Precisely. If the pressure dynamics shift, perhaps through manipulation of the abscess or simply due to the local inflammatory response bacteria, can be swept into the extracranial venous system.
Travel retrogradely through the valveless emissary veins, bypass all the robust bony and dural defenses, and empty directly into the cavernous sinus or the superior sagittal sinus.
An extracranial superficial infection rapidly evolves into a catastrophic intracranial pathology.
Okay.
Cavernous sinus thrombosis, purulent meningitis, or an epidural abscess.
The evolutionary advantage of thermal regulation and pressure equalization comes at the tremendous cost of leaving a back door open to sepsis.
It is a calculated evolutionary compromise.
Absolutely. Moving from the venous gateways, we must systematically map the neural gateways.
The 12 pairs of cranial nerves must exit the neurocranium to innervate the sensory organs, the musculature, and the viscera.
And rather than memorizing a disjointed list, we should trace them spatially, moving sequentially from the anterior fossa to the posterior fossa. The architecture makes logical sense.
Let's construct that spatial map. I am standing in the anterior cranial fossa, right behind the frontal bone, looking down at the floor.
Okay, in the anterior fossa, straddling the midline, is the cribriform plate of the ethmoid bone.
Sieve-like.
Yes, cribriform signifies sieve-like. It sits adjacent to the crista galli we discussed earlier. Cranial nerve faith, the olfactory nerve, does not exit as a single thick trunk.
Instead, its delicate sensory filaments plunge downwards through the multitude of tiny perforations in the cribriform plate,
Accessing the roof of the nasal cavity directly below to mediate the sense of smell.
Fractures of the cribriform plate are notoriously tricky because they can tear those olfactory filaments, causing anosmia, but they also tear the arachnoid and dura, leading to cerebrospinal fluid rhinorrhea CSF leaking out of the nose.
Very true. Stepping slightly posterior into the middle cranial fossa.
We arrive at the body of the sphenoid bone.
Here, cranial nerve sedent, the optic nerve, exits through a dedicated, thick-walled cylindrical tunnel called the optic canal.
It carries purely visual sensory information directly into the posterior apex of the orbit, accompanied by the ophthalmic artery.
So CN takes the sieve, CN2 takes the clean tunnel. Moving laterally from the optic canal, we encounter that incredibly congested region we discussed during the fistula segment.
We are looking at the superior orbital fissure.
It is a large, oblique, teardrop-shaped slit situated between the greater and lesser wings of the sphenoid bone.
It acts as the primary neurovascular conduit for the orbit.
Slipping through this fissure are all the cranial nerves responsible for extraocular muscle movement. CN3 oculomotor, CNIV trochlear, and CNV abducent.
Furthermore, the ophthalmic division of the trigeminal nerve, V1, utilizes this fissure to reach the orbit and ultimately the skin of the upper face and forehead.
The eyes command a staggering amount of neural infrastructure.
What about the rest of the facial sensation handled by the trigeminal nerve?
The remaining divisions of the trigeminal nerve drop vertically through the floor of the middle cranial fossa. The maxillary division, V2, mediating sensation for the midface, exits through a perfectly circular aperture, the foramen rotundum.
And just posterior and lateral to that, the mandibular division, V3, carrying sensory fibers for the lower jaw and motor fibers for the muscles of mastication, exits through an oval-shaped aperture, the foramen ovale.
Rotundum for the midface, ovale for the lower jaw. Moving further posterior, we cross the petrous ridge of the temporal bone and descend into the deep posterior cranial fossa beneath the canopy of the tentorium cerebelli.
Carved deeply into the posterior surface of the petrous temporal bone is the internal acoustic meatus.
This bony tunnel transmits cranial nerve 7th, the facial nerve, and cranial nerve 8, the vestibulocochlear nerve.
CN8 terminates in the inner ear to manage hearing and balance, while CN7 continues through the complex facial canal to exit the skull base at the stylomastoid foramen, eventually innervating the muscles of facial expression.
We are approaching the major drainage point.
We reach the jugular foramen, the large, irregular, jagged opening situated between the temporal and occipital bones.
As we mapped earlier, this is the exit route for the sigmoid sinus as it transitions into the internal jugular vein. But it is also a vital neural gateway.
Hitching a ride alongside that massive venous outflow are cranial nerves, nayax, glossopharyngeal, X, vagus, and arava accessory.
They all utilize the jugular foramen to escape the cranial vault and descend into the neck.
Which leaves only one cranial nerve.
Cranial nerve 12, the hypoglossal nerve, which provides motor innervation to the intrinsic and extrinsic muscles of the tongue. It possesses its own dedicated private exit right at the margins of the massive foramen magnum, the hypoglossal canal.
That spatial mapping flawlessly ties the entire chapter together.
It really does.
If we synthesize the vast amount of anatomy we have covered, the central narrative is undeniably clear. The cranial fossa is an absolute masterclass in structural and functional engineering.
The duramater operates simultaneously as an unyielding protective shield, a complex internal scaffolding system, and the rigid architecture for fluid dynamics.
The dural venous sinuses completely subvert systemic vein mechanics, relying instead on rigid geometry and unrelenting pressure gradients to maintain cerebral perfusion and drainage.
And critically, we have demonstrated how that hyper-specialized anatomy dictates pathology.
A severed artery beneath the tight periosteal dura creates the delayed devastation of an extradural hematoma.
A fractured sphenoid bone within the congested cavernous sinus initiates catastrophic retrograde venous failure.
Anatomy is the precise study of structure in service of function, and how that structure shapes disease, intervention, and outcome.
Absolutely.
All right, to ensure these complex spatial and functional relationships are fully integrated, let's transition into our clinical application.
Let's do it.
I am going to present you, the listener, with 6 single best answer scenarios. Think of this as a rapid-fire multidisciplinary team discussion. I'll lay out the anatomical or clinical problem, give you a brief moment to form your judgment, and then our expert will break down the structural reasoning behind the correct diagnosis. Let's test the model. Ready?
Okay. Ready when you are.
Scenario 1. A neurosurgeon is reviewing an MRI to plan an approach to a pineal gland tumor. They note the tumor is displacing a rigid, horizontally positioned dural reflection that physically separates the cerebellum from the occipital lobes of the cerebrum.
Okay.
Which specific structure is being displaced? Is it A, falx cerebri, B, diaphragma sella, C, tentorium cerebelli, or D, falx cerebelli? Lock in your structural identification.
Well, the correct diagnosis is C, the tentorium cerebelli. The key functional identifier here is horizontal separation. The tentorium acts as the horizontal roof over the posterior cranial fossa, supporting the heavy occipital lobes above and protecting the cerebellum below. The falx cerebri, A, and falx cerebelli, D, provide vertical midline partitioning, while the diaphragma sella, B, is highly localized to the pituitary fossa.
Spot on. Let's move to a trauma scenario. Scenario 2. A 22-year-old patient presents to the emergency department following a lateral blow to the head with a cricket bat.
Ouch.
They experienced a brief loss of consciousness, followed by a period of complete lucidity lasting 2 hours. They are now rapidly deteriorating, demonstrating profound drowsiness and a fixed, dilated pupil on the side of the impact.
Classic.
A CT scan reveals a biconvex hemorrhage between the calvaria and the dura mater. Which specific vascular structure has most likely ruptured? Is it A, superior sagittal sinus, B, middle meningeal artery, C, internal carotid artery, or D, great cerebral vein? Trace the pathology back to the source.
The culprit is B, the middle meningeal artery. This scenario perfectly describes an extradural or epidural hematoma. The middle meningeal artery grooves the inner table of the skull, running entirely external to the periosteal layer of the dura. A fracture at the fragile pterion tears the artery, and the high-pressure arterial bleeding hydraulically dissects the dura from the bone. The superior sagittal sinus, A, is a venous structure located superiorly and medially. The internal carotid artery, C, traverses the cavernous sinus deeply at the skull base.
Excellent. Scenario 3. During a tutorial on cerebral vascular physiology, you are asked to explain the functional mechanics of the intracranial venous drainage system. Which of the following statements accurately describes the fundamental architecture of the dural venous sinuses?
Let's hear the options.
A. They rely on one-way intimal valves to prevent retrograde flow. B. They are dynamically contractile spaces formed by the separation of the pia mater. C. They are rigid endothelial line channels dependent entirely on pressure gradients. Or D. They expand and contract dynamically in response to arterial pulse pressure. Think about the physics of the upright posture.
The correct physiological principle is C. Dural venous sinuses are completely rigid, valveless spaces formed by the separation of the periosteal and meningeal layers of the dura mater. They lack a tunica media and cannot contract, ruling out B and D, and they possess 0 valves, ruling out A. Flow direction is maintained strictly by continuous pressure gradients feeding into the rigid system.
Brilliant. Scenario 4. A 45-year-old patient is involved in a high-speed motor vehicle collision, sustaining a severe comminuted fracture of the sphenoid bone at the cranial base. 24 hours later, they develop pulsating exophthalmos, severe conjunctival ecchymosis, and a fixed, dilated pupil.
We covered this.
We did. You suspect an arteriovenous fistula within the cavernous sinus. Which cranial nerve, embedded within the superior aspect of the lateral wall of this sinus, is typically the first to demonstrate clinical failure due to the acute outward mechanical pressure? A. cranial nerve the third, oculomotor. B, cranial nerve the sixth, abducent. C, cranial nerve 2, optic. Or D, cranial nerve 7th, facial.
The primary nerve affected is A, cranial nerve 3rd, oculomotor. While cranial nerve 6th, the abducent, runs through the central venous pool and is highly vulnerable, CN 3rd is tightly embedded within the superior aspect of the lateral dural wall. As the arterial blowout massively engorges the sinus, the rigid lateral wall is bowed outwards, severely stretching and compressing CN 3rd, compromising its parasympathetic fibers first and resulting in a dilated pupil.
Right on the money. Scenario 5. A pediatric patient presents with signs of acute bacterial meningitis. History reveals they had a severe, untreated staphylococcal furuncle, a boil on their upper lip 3 days prior.
The danger triangle.
Exactly. The medical team suspects the infection spread retrogradely into the intracranial space. Which specific vascular structures serve as the valveless bidirectional conduits, permitting this extracranial to intracranial spread? A, diploid veins. B, emissary veins. C, meningeal veins. Or D, internal jugular veins.
The correct answer is B, emissary veins. Emissary veins traverse the calvaria, directly linking the extracranial venous system of the scalp and face to the intracranial dural venous sinuses. Because they lack valves, blood flow direction is dictated entirely by pressure, providing a direct, unguarded pathway for superficial infections to enter the sterile cranial vault. Diploic veins, A, remain confined within the spongy marrow of the calvarial bones.
Final scenario, mapping the gateways. Scenario 6. A patient with a maxillofacial fracture presents with profound anesthesia over their midface, upper lip, and maxillary teeth. You suspect impingement of the maxillary division of the trigeminal nerve, cranial nerve V2, as it exits the middle cranial fossa. Through which specific osseous gateway does this nerve division traverse? A, superior orbital fissure. B, foramen ovale. C, foramen rotundum. Or D, jugular foramen.
The structural gateway is C, the foramen rotundum, to reconstruct the trigeminal map. V1, ophthalmic, exits via the superior orbital fissure. V2, maxillary, exits via the perfectly circular foramen rotundum. And V3, mandibular, drops through the foramen oval.
Fantastic. If you successfully reason through those scenarios, your spatial and functional model of the cranial fossa is robust and clinically applicable. Before we conclude, I want to leave you with a provocative evolutionary concept to consider in your independent study.
Oh, this should be good.
We discussed the tremendous, life-threatening vulnerability introduced by the emissary veins. The fact that they provide a valveless, bidirectional highway for lethal superficial infections to invade the brain. From a purely defensive standpoint, sealing that pathway seems obvious. So why didn't we?
A fair question.
Consider the radiator theory of human evolution. As early hominids developed massively expanded cerebral cortices, the brain became an extreme heat generator. In the high ambient temperatures of the African savanna, the inability to cool the brain during sustained physical exertion like persistence hunting would lead to fatal hyperthermia.
Right.
What if the emissary veins aren't a flaw, but the critical thermal adaptation that allowed the human brain to scale up in size? What if leaving the back door open to infection was the necessary physiological trade-off for possessing the cognitive capacity to build civilization?
It is a profound question regarding anatomical compromise. It reinforces the central premise we established at the very beginning of this deep dive. The structures we have mapped today are not arbitrary shapes carved in bone. Anatomy is the study of structure in service of function, and how that structure profoundly shapes disease, intervention, and the long arc of human outcome.
Here are the details of this episode.
Cranial fossa, the chamber of protection and passage. Byline: a vaulted chamber beneath the skull where protection meets pressure and every pathway carries consequence.